We're glad you could join us today for the ECG webcast, the CARES Act, Regulatory Implications and Next Steps. I'm Terry Welter, a principal at ECG, and I'm pleased to be your moderator for today's session. During today's presentation, our speakers will discuss the federal government's enactment of two major pieces of legislation providing support to healthcare providers amidst the COVID-19 pandemic: the Families First Coronavirus Response Act and the CARES Act. In this session, ECG will help hospitals and health systems understand the financial impact of these bills and how organizations can use this legislation to serve their communities during this crisis and remain financially viable. Before we introduce today's speakers, let's go over a few details about the webinar. Today's program will be 30 minutes in length. There will be 20 minutes of questions and 10 minutes for Q&A. Everyone should have received a copy of the session handouts, but if you were a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen mode only, but if you have questions, you can type them in the questions pane on your screen at any time, and we'll address them at the end of the program. If we're unable to get to your question today, we will follow up with you directly after the session. And finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is very important, so please take a minute to complete the survey. For each completed survey, ECG will make a donation to Doctors Without Borders. Now let's meet our speakers. Katie Fallon, a senior manager at ECG, is focused on helping provider organizations define and implement practical managed care strategies. Katie frequently supports clients in development of current state reimbursement assessments, identification of revenue opportunities, and payer negotiations. Mark Johnson is a senior manager in ECG's strategy practice. Mark advises health systems on strategic and financial planning initiatives with a focus on partnerships and transactions. Mark's background in financial planning allows him to give specific and actionable insights to the leadership of hospitals, medical groups, and health systems. Jim Ryan, a senior manager at ECG, helps providers optimize reimbursement from payers. His deep knowledge of reimbursement methodologies helps him identify appropriate payer contracting opportunities for his clients based on their unique goals and attributes. Thanks to all for joining us. Just want to do a quick note on ECG for those that don't know us. So ECG is a national consulting firm. We focus on the healthcare industry solely in strategic finance operations and also in technology. We've been around for 50 years and have approximately 250 consultants in the U.S. I think we know personally many of you on the call today. And what we've been doing through the COVID crisis is making sure that we're keeping as up to date as we can. We've been working with a number of you, and our goal of this session is to really help you understand very specifically where we think you have an opportunity to access some of the funds through the two acts that we'll be talking about. If I know that we're not going to have time to get to all the questions, but we will personally follow up with each of you for the questions that you submitted. So moving to the agenda, we intentionally left this agenda for 30 minutes again, so we'll follow up after if we don't cover things. We're going to focus first on the macro part of the way we see the current situation from a financial standpoint, and then go into very specific components of the legislation. We're going to walk through an example of a client that we've worked with, that the implications of the current state to them, and then get into some specific recommendations before we get to Q&A. And again, our primary goal is for you to walk away having some very specific actionable areas where you can turn to in terms of where to access the funds, how to access the funds through these latest acts. So moving on to the next slide, slide 5. If you look at the current state, I mean, our healthcare system essentially was designed to be financially paid based on volume. So if you look at the current state of things, we have certainly the pandemic across the entire country. But what's happened is we have a lot of the markets not seeing any the number of cases of COVID cases that they are in the hot spots. So we have a very specific financial situation going on, particularly in the areas where there's not hot spots. So if you look at the map, you can see that there's a number of providers that we're anticipating will lose a significant revenue during that period. So the reality of the situation is that we think we have kind of a pretty big math problem. When hospitals have foregone elective and non-essential services to prepare for this, they've seen a major decline in revenue. To review this at a macro level, hospitals and their employed physicians we anticipate will see a $120 billion reduction from expected when we compare that to last year, and we think that's going to be about a 10% reduction overall. We think that mid-size and rural markets will be disproportionately hurt, and this doesn't even include additional burden of cost for preparation costs. So again, our goal in the webinar is to go through some very specific information about how you can access these funds. And with that backdrop, I'm going to turn this over to Mark so he can talk about some of those specific elements of the bill.
Thanks, Terry. Appreciate it. As Terry mentioned on the previous slide, the hospital executives that we've been speaking to are increasingly concerned with the revenue impact in really two main areas. So the first is the one that you hear about most, the decrease in elective volume, which really makes up the largest portion of that decline. But we're also seeing a fairly large decline in emergency department volumes. And so those two together represent a fairly sizable hole for health systems to dig out of. And so in order to assist in making this up, the federal government's recently passed two pieces of legislation, the Family First Coronavirus Response Act, and also the Coronavirus Aid, Relief, and Economic Security, or CARES Act. And so the provisions outlined in these laws offset some, but really not all of the revenue losses that hospitals are expected to experience. And so we've modeled out the impact, at least to an example health system here, to show really how each of the main provisions in the law will help to fill that hole. The provision that's garnered the most publicity has been the additional 20% payment for any case with a COVID-19 diagnosis. And that provision, coupled with the expected volume in a non-hotspot hospital, makes up only about 2% of the projected shortfall. Certainly, hotspot hospitals would see a larger figure there. Next is that cuts to disproportionate share payments, or DSH payments, that were supposed to go into effect in 2020 will be postponed, and then will be cut in half in 2021. And so similar to the prior example, the impact here would be highly variable based on the amount of DSH payments that a given system receives. In this example, it was fairly impactful at a 7% offset. Similar to the postponement of DSH, the 2% reduction in payments due to the 2013 sequester will be suspended until the end of this year, and that offsets about 3% of the losses that we're observing. The Families First bill increased the FMAP ratios, which is used to determine matching Medicaid funding in states. And so in our modeling, that serves to offset this gap by 2%. And then finally, in a fairly sizable offset, the Public Health and Social Services Emergency Fund, which is going to be controlled by the Health and Human Services Administration, if allocated like we think it will across the country, which would be by the number of beds in each hospital, that would represent a fairly sizable offset of 23%. Before moving on also, I think it's important to point out some cash flow impacts as well. So hospitals can receive payment for up to 6 months worth of Medicare services. And this really serves as a loan. Those have to be paid back through future billings, as well as payroll taxes can be deferred. So these two provisions will help in the near-term cash flow for a lot of health systems, but really won't help from a revenue standpoint going forward. With that, I'll kick it over to Katie and let her continue to speak about some of the detailed modeling that we've done.
Thanks, Mark. And it's pretty evident from our first couple of slides that the funding amounts that have been cited through the various stimulus provisions are pretty broad, and they've left many provider organizations asking, how do I estimate the financial impact for my own organization? So to make the relationship between the elective volume reductions that a lot of providers are experiencing and the proposed funding in the CARES and Family First Acts a little more relatable, we thought it would help to look at an example independent health system that is already experiencing those elective volume reductions, but is located in a region not yet experiencing and not yet projected to experience significant COVID-19 cases. So we developed a model or a calculator, if you will, with the goal of understanding if COVID-19 admissions actually help offset the elective volume reductions, and then to what extent the stimulus provisions provide adequate financial relief for hospitals. So on the next couple of slides, I'm going to talk through the volume assumptions and the impact on patient revenue. And then I'm going to turn it over to Jim, who's going to talk through the stimulus funds. And then he's going to tie both components of the analysis together to show you the revenue and cash flow impact for this example health system. So let's move on to slide 8 to talk about the volume and reimbursement assumptions that we built into the model. Now, the volume assumptions in our modeling are really centered around 2 key areas. The first are reductions in elective volumes, and then the second are projection of new COVID-19 admissions. Let's start with the first. To develop the assumptions about reductions in elective volume during the COVID pandemic, we used this sample health system's actual experience in the last half of March as a starting point. So in the last half of March, this health system's experience included an almost 100% reduction in elective case volume and up to a 50% reduction in other areas like the emergency department. So what you'll see here on this slide is that our final assumptions used in the model mirror that last half of March experience. They include a nearly 100% cessation of elective services for April and May. We have a gradual increase in elective volumes throughout June, July, and August, and then a full return of elective volume by September. We applied these volume reduction assumptions to this health system's actual calendar year 2019 encounter data so that we could calculate the corresponding revenue impact. The other side of the volume equation is projection of new COVID-19 admissions. And for that, we used the COVID-19 admission projection for this health system state from the Institute of Health Metrics and Evaluation, or the IHME. And from those state level projections, we were able to develop an estimate of this health system's predicted number of admissions based on a combination of market share, patient age group, and payer mix. And then we also estimated the number of those admissions that would require a ventilator. So once we had the COVID-19 admissions estimated, we then used that same calendar year 2019 encounter data and the COVID-19 specific DRGs that CMS identified to determine a revenue per case estimate for both the COVID-19 admissions and the COVID admissions with ventilators. And then finally, and Mark mentioned this, if you recall, the CARES Act included a 20% increase in the DRG weight for all Medicare discharges with a COVID-19 primary or secondary diagnosis code. So we applied that 20% increase to the DRG weight for all projected Medicare and Medicare Advantage admissions in this model. So let's look at the results on slide 9. So using those assumptions we just discussed, this example health system is projected to experience an $84 million reduction in patient revenue for calendar year 2020. Now, from the time we started this analysis, which I think was right around Monday, March 30th, to just this past Monday, just about a week, the IHME state COVID admission projections decreased by more than 50%. And so the corresponding result of that is that because the admission projections went down, the anticipated COVID admission revenue that this health system was expecting also went down. So what you'll see here is that the health system is only going to gain about $1.8 million in revenue based on the COVID admissions, and that's inclusive of the 20% increase in the DRG weight for the Medicare admissions. You see that there in the middle of the slide. That's only accounts for about $300,000. So this health system is now left with a projected, 82.2 million patient revenue shortfall. And we believe this is likely consistent with the reality that many other health systems located out of COVID-19 hotspots are facing. So it kind of leaves us with a situation here. So patient revenue from COVID-19 admissions and that 20% bump from the DRG rate for Medicare admissions do very little to offset the patient revenue losses as a result of the declining elective volumes, then the question really is, to what extent will the stimulus provisions help either offset revenue losses or at least help free up additional cash in the short term? So I'm going to turn it over to Jim to walk us through that next piece of our modeling.
Thanks, Katie. So slide 10 details our assumptions about the impact of this legislation on the example health system's revenue and cash. The first thing we looked at was the Medicaid DSH reductions, and this health system was expecting to receive $10.5 million less in annual DSH payments as a result of the cuts that were originally scheduled for May. So we estimated that delaying those cuts for a little more than 6 months from May to the end of December, or to the beginning of December, should lead to about $5.5 million more in DSH payments in 2020. It's actually a little bit debatable whether this delay is going to result in additional revenue or cash for health systems. If those cuts for May weren't baked into your expectations for DSH payments already, then maybe you wouldn't consider these to be something that increases revenue. But in this case, we counted the DSH delays as additional revenue. Next thing we looked at was the suspension of the Medicare sequestration adjustments from May to December. And for this time period, we simply increased any Medicare and also Medicare Advantage payments by 2%, the amount of the adjustment. Next, we looked at the FMAP funding increase, the 6.2 percentage point increase in each state's federal matching rate for Medicaid payments. This could actually result in states getting hundreds of millions or even billions in additional Medicaid funding if the public health emergency goes on for the whole year. We think most of this funding is going to go to providing Medicaid coverage to more people, as unemployment rises. But we do think some of this funding is going to flow directly to hospitals in the form of additional DSH payments. In the state where this health system is located, usually about 13% of their Medicaid budget goes towards DSH payments, and about 4% of that DSH budget goes to the health system. So we assume those percentages would apply to the additional $300 million that the state is projected to get thanks to the FMAP increase. Next thing we tried to do was estimate how much of the public health and social services emergency fund would go to the example health system. We're still awaiting guidance from HHS about how those $100 billion funds are going to be distributed. Supposedly this week they're going to distribute $30 billion based on Medicare revenue, but even beyond that, the specifications are pretty limited. In our projections, we assume that a little more than 60% of the $100 billion fund ultimately is going to flow to hospitals, and that hospital share would be distributed at an equal per bed rate to every hospital in the U.S. We'll caveat that by saying this is really our best guess, and the figures and how HHS decides to distribute that fund could be very different from what we projected here. We just tried to come up with a reasonable estimate. And then there's some provisions that impact cash but not revenue, so we want to call those out as well. The one I'll focus on here is the CMS Accelerated and Advanced Payment Program. For this program, we assume that the example health system, because it includes acute inpatient hospital, could get 6 months worth of its 2019 Medicare facility revenue in the form of an advance payment. If we go to slide 11, you can see some of the figures that these assumptions led to. And if you look at the revenue impact from the legislation, all of these various provisions, they add up to about $29 million in revenue for this example health system. And that is obviously well short of the $82 million reduction thanks to volume that Katie described a couple of slides ago. So this is going to lead to a $53.4 million revenue shortfall that the hospital is going to have to overcome at some point. Now, the cash flow opportunities should certainly help, and you can see that the CMS Accelerated and Advanced Payment Program amount that we estimated of $86 million, that's actually a little bit more than the $82 million revenue impact that we're projecting. Just bear in mind that Medicare is going to start making recoupments to recover that $86 million after 4 months. So to some extent, that advance is just delaying part of the revenue problem by a few months. That being said, we think most health systems could use all the cash that they can get right now. So applying for the Medicare advance payments is definitely one of our recommendations to health systems. And I'm going to turn the program over to Terry now to talk about that and our other recommendations in greater detail.
Thanks, Jim. So let me just quickly summarize this. As Jim said, one of the most important things we think you should do right now is to apply to take advantage of the Accelerated Advanced Payment Program. The application is what we've shared in our notes, sort of more detail on how you can access the application. We learned on Tuesday that as of that point in time, there were 25,000 applicants, 17,000 were approved. They're approving them very quickly, and cash is supposed to be starting to be distributed within the next week. So this is something, as Jim said, you're going to have to pay it back. We think that will stay, and that payback requirement. But I guess at this point in time, anything's possible. But the other thing I think that's important to know is that this applies to Part A and Part B providers and suppliers. So that means physicians are eligible, APPs are eligible, DME providers are eligible as well. So certainly it's something for physician group practices to make sure that they access. There's various requirements on when the payback, the time frame for the payback. But again, we think it's really important because this is going to help you to shore up some near-term cash. So if we jump to slide 13, a couple of quick areas. We think you need to complete these financial projections. This is really important to understand sort of what your gap is from a revenue standpoint. Obviously, you're going to need to look at your costs as well. We think you should be prepared. As Jim said, there's guidance coming out for the PHS-SEF opportunity. Be prepared to understand sort of what you're going to ask for in that. Doesn't mean you'll get all of it, of course, but certainly you need to know what your gap is anticipated. We think you should push for additional legislation locally, statewide, federal lobbying efforts, plus your local politicians. You should lobby to them. And we also think one of the most important things is that you really start to think about a very specific plan for getting patients back into your organization safely. If you look at the current state, you've got a population of patients that are fearful of their safety. We're going to, as an industry, going to have to really work hard to make sure that we have a plan, that we're working closely with our physician community in communicating to patients. There's all kinds of regulatory eases out there around place of service. So, for example, we've shared on here a piece that we have on ASCs and how patients can access ASCs. We think as soon as that shelter in home or less stringent requirements are eased, that you're actually going to see a pent-up demand come back, and obviously you're going to want to be ready for that. So that's going to be an important piece financially, but also just to continue to serve the community that needs the care because they've been at home. So if we move to slide 14, access to FEMA funding. This is something that the federal government has put out that will essentially give you an opportunity for certain emergency costs that you put in place. They'll do a 75% cost share. We also shared a note here where you can access more information about that the AHA guidance has put out. But that's a certain opportunity for many of you. We've heard about a number of our clients filing business interruption insurance claims. We don't feel terribly hopeful about that option, but it's certainly something that you should look into. What we've heard, the advice that we've gotten is that you need to check your coverage policies on that because sometimes there's a virus exclusion clause. And then lastly, but the last one that we'll comment on here is working very closely with the payer community. We're starting to see an increase of payers getting involved in doing advanced payments or expediting payments or even providing loans to the provider community. We're seeing that more in the areas, for example, in Washington State, that's starting to happen. We think that payers, while they currently have short-term claims that have gone down. They actually are worried about long-term membership shifts with the unemployed increasing. So that being said, we've seen some early opportunities that payers are willing to work with their provider community to help ease the burden. So that's something that is very, very important for you to do. Okay, moving into 15. That is really the end of the formal part of our presentation. So what I'm going to do now is just remind you that if you have a question, looks like we have 4 to 5 minutes left. If you have a question, put it into the panel, and if we don't answer it now, then we'll certainly be sure that we answer it as a follow-up. So let me start off with, I'm going to ask a question of Jim. So is there a timeline deadline to claim any pieces of the funding that we talked about? Can you comment on that, Jim?
Sure. There's not any real imminent deadlines that we're aware of. The Medicare accelerated payments are going to last for the duration of the public health emergency. So if you wanted to wait a little while to apply for those for whatever reason, you should have some time, and you should receive those payments within a week of application if they're approved. The Public Health and Social Services Emergency Fund, the $100 billion fund, the first $30 billion tranche, which is supposed to go out soon, is not going to be on a first come, first served basis, but additional payments from that fund may be. So that's why we recommend kind of preparing your ask and your justification for that ask. And then for the FEMA funds that you mentioned, you can apply for those for up to 30 days after the end of the public emergency declaration. So assuming that public emergency goes on for another few weeks or months, there should be some additional time to apply for these items.
Thanks, Jim. I'm going to direct the question at Mark next. So, Mark, how are CFOs planning for the pending recovery after the crisis is over?
I think probably a crisis like this tends to highlight areas of weakness for organizations. And so one of the things that we're getting questions on almost immediately is on revenue cycle. And I'm sure that as things start to recover, that'll be an area of focus, because there's really no better time to fix issues around that than in good times. But also we're hearing a lot on health systems looking for low capital initiatives. Things like building a more aligned physician enterprise can often be relatively low capital, in that, a lot of those transactions are not done at a multiple and are certainly much more manageable than, say, new towers or new facilities. And so because of that, we are getting quite a bit of interest and discussion around physician alignment activity.
Thanks, Mark. I'm going to keep it with you. It looks like we probably have time for one more question. And again, we have lots of questions, so we'll get these back to you all after the program. So, Mark, what's the impact? What do you think? And this is a big question. We've been hearing it frequently. What do you think the impact is to small medical practices?
Yeah, I mean, it's tough, because there's generally not even close to the reserves in small medical practices that hospitals and health systems have. I think, there's one big provision in the CARES Act that we talked about around the Medicare Advanced Payment Program, which is really 6 months of pay or 6 months of a loan, really. Medical practices can receive 3 months, and so although it's a lower amount, it's still beneficial to apply. And then also, the CARES Act provided for additional funding for Small Business Administration loan and grant programs. And so the American Medical Association actually has a great write-up on how to access those funds. And I think it would be well worth looking into if that's something that you're interested in.
Thanks, Mark. Actually, thanks to all three of you. All right, so I think we're out of time, and I know everyone's schedules are very busy. So I just want to thank you again for joining us. Remind you again that we are committed to getting your questions answered. We're also going to have a series of additional webinars that will cover what the topics that we know are most important to you all. So we'll be communicating about that. You can see on the slide deck that here's a listing of some additional details that we put in, various blog posts, various thought leadership that we've been putting out. So we encourage you to draw on those. We encourage you to call any of us with any of these questions. And I want to remind you again, if you could take the time to fill out the survey, let us know how we did, whether this was helpful to you. It's important for us to get your feedback, and for every survey that you complete, we will make a donation to Doctors Without Borders. So thanks again, everyone, for joining, and stay well and have a great day.